So as compared to Delhi presentation, this is mild, sober, and polite, and yeah, the usual cultural differences. Hello, Chris.
Yes, hello.
This is Ashwin Mehta. To me, next to me is Robin Chakrabarti, and then T.S. Clare, Dr. Vijay Bang, then I think Dr. Singit Valu, and Dr. Ten from, Dr. Ten you know very well, from Singapore, and then Dr. Madikar, Dr. Rehman, and there's a big orchestra here.
Yeah, so it's many friends. Hello, it's very good to be here. Thank you very much for the invitation. We are here in Apollo Hospital. I'm here with Shalup and the entire team from Apollo Hospital, and we have a quite very interesting case, I believe. And I think Shalup will take you straight into the case, and then we can discuss.
Well, I can't clearly hear you. Can you hear it?
Hello everyone, I'm Shalup here.
Can the audio
Voice
be
is not
improved?
clear.
We can hear you.
On the other side, we cannot hear it clearly.
Yeah.
Okay.
Meanwhile,
hear?
can you so tell us the story of the patient?
Yes, we will.
This is a next slide.
Just go.
This is a 58-year-old male. He's a known hypertensive and smoker, not a known diabetic. He had a history of TIA 6 years back. Now presented to us with grade 2 angina. His vitals are stable. Blood pressure is around 160/90. Next slide. This is the ECG. You can see fairly not much STT changes. Echo. Echo, there is a mild hypokinesia of LV apex and basal IVS, otherwise adequate LV systolic function. So his angio is?
We have the angio. So the previous angio showed the distal left main 60%, 80% bifurcation lesion involving the ostial circumflex, and he has also a trifurcation lesion distally, and the RCA has also stenosis.
So, a 90% lesion.
RCA has also 90% lesion.
Which we are planning to do it.
And they are planning to do it this stage. Now let's go to the angio images that we have here. Syntax score is 22. Can I see the angio? Okay. Now here you see our first angio image. You can see that there's a lot of plaque in the distal left main and also heavily diseased circumflex, quite long lesion, let's say at least 10, 15 millimeters into the circumflex. But what you can appreciate that there is also, yeah, here you can nicely see the plaque in the distal left main and the diseased circumflex. Can I have the next, please? But here you see, yeah, leave this here. This is the trifurcation lesion of the LAD further down. It's very, very tight. We have two diagonals arising from there, and then a quite big LAD coming from there. And you can see also some calcium if you look closely. So our target is today the full left coronary artery. We will not treat the right today. This will be done later on. And the question is now on the strategy. And if you want, I can take you into your strategy, into our strategy, or you can have a short discussion, whatever you like.
Right. So can we have some comments from the panelists?
What
Meanwhile, for the audience, did you
about
see?
right coronary?
Right coronary, yes, right coronary, please.
What about right coronary?
Yeah, I didn't see the image here, but the right has in the mid portion has a high degree stenosis, which will be treated later on.
Okay. Did you see that both the cases have a Syntax score of 22? So it is a 22. Today is 15th, by the way. Can you have some comments from the panelists?
Hi, Chris.
This patient is a diabetic and a triple vessel disease.
He's not a diabetic, sir.
It's
not
not
a diabetic.
okay. It's a left main disease. Then there is a trifurcation of the LAD, and I am told that there is a tight lesion in the right coronary artery. I would personally think that in a country like India, because of the cost involvement, I think surgery would be a better option. Anyhow,
Patient is not
I
very
can
keen.
see the vessels are not calcified. I think it's a very doable case. It's very nice and challenging case, and I would love to see the outcome.
Okay, maybe I can comment quickly on that before we show you the steps and explain the strategy, because we need to proceed. So we talked to the patient, at least not me, but the colleagues here talked to the patient in length, and he's quite not keen on surgery. That was discussed with the family back and forth, and obviously I cannot comment on that. The decision was that they would like to undergo PCI. I discussed the same with the colleagues. I also see an option for surgery, but we also believe it's doable, despite it can be quite challenging. So maybe let me take you through what we did so far and then talk about our strategy. Our first strategy was to treat the LAD lesion first. And here you see we are entering the LAD with a fielder wire. We wanted to also wire the diagonal branch. Here you can see the wire on the diagonal branch. And then we said, depending on whatever happens, we would like to dilate. And you can see that even a 2.5 balloon doesn't cross the LAD lesion. Next.
It was a 2 balloon.
It was a, no, 2.5. And now, it was a 2, 0?
2, 2,
okay, now 1.5 crosses. Next, please. Patient has chest pain, which is expected. We are dilating several times. Here again, you see it does not fully open.
This is a single, what balloon is this? How much? 1.5?
1.5.
This is 1.5. Yeah, you can see from the middle marker. It's a 1.5 mini
1.5, definitely.
Yeah, next.
The balloon is sleeping.
Yeah, patient is having chest pain. He's quite anxious. Here you see the first result. And yeah, next. And now we take a bigger balloon because we couldn't cross with a stent. Our plan was to take a 2.5 stent and to make it then afterwards a little bit bigger. So this is a 2.5 balloon. We took it to quite high pressures, and we are dilating several times here. Okay. Next, please. You see the fielder always comes out. Now, this is 28 2.5, because we thought it's a drug eluting. It's a science alpine. And next, please. Next, please. Our plan was to bring it a little bit further down. So here, this is a good implantation position because we're covering the full disease segment. And now we took it up to 2.5, 27, and we took it up to 16 atmospheres. And you can see that we have quite some challenge here in the proximal part with the calcium. Next, please. Here you see it's nicely expanded now. Next, please. Next, please. So this is our first injection. We have good flow in the diagonal. Our plan was to keep the diagonal simple because we still need to treat the left main. Next, please. Now what we did was we took a short 3.0, I think 15 or 10?
8.
8, oh, it's 8. And we took it up to do a pot. Here you see the pot. Next. Now it's better expanded here, but still not fully. And then we dilated the tighter part. Next, please. You can see the same here, also not fully, but better expanded. And you see quite a good result. Next, please. Now we took back the wire and pushed it down. Again, it's a BMW now in the LAD. Next, please. Next. Okay, these are thought to be our final shots on this. One, and the next in the spider. And here you see that we still have a big proportion of calcium. So we decided to go with very high pressure with the 3.5 balloon again.
3.30.
3.0, sorry. Next, please. Next, please. Next, please. Yeah, here you can see we are going up to 22, 24 atmospheres. Next, please. Okay. We believe at the moment this is the best we can get. We have some impingement of the diagonal, but it's not too big. We have quite a good flow. We would like to leave it now because manipulating too much in this big plaque in the circumflex ostium and the distal left main could cause some problems. And we would like to proceed now with the left main.
I think you got getting
Very good, but Claire, I think both the cases had a syntax score very similar. And yet I think this particular one is more demanding than the other one.
No doubt.
Yeah, so that was the syntax score can translate your ability to do the cases comfortably is not true. Like it is different. Like,
See, the thing
like
is-
you rightly said, that you will not be, you will be happy to send him
Go
to
in the
surgery
spider, go
also
in the
in case
spider,
of the
go in the
overall
spider.
circumstances
Spider.
demand. I totally
Spider,
agree with you.
2.520
I
balloon.
totally agree with you, and I think even
2.520.
electively also, somebody who does not want to take a stress of a complexity of this case can also think of sending the patient to surgery also.
No, it's not a question of taking the stress. It's a question of even the long-term results in a patient.
Yeah.
You know, this is a trifurcation of LAD, then
2.520
there's left
balloon.
main disease, then the circumflex is arising 90 degree.
Yeah.
And there is a at least 15% chance that he will develop stenosis of the circumflex ostium after
Yeah.
the stenting.
True.
We know that, we have the experience. So this patient, certainly my choice will be surgery. For the previous case, Dr. Seth's patient, I will prefer angioplasty. Why? Because LAD is diffusely disease. There are 3 lesions. There is proximal, there is mid, there is distal lesion. I don't know whether the surgeon will be able to do revascularize all the 3 segments or not. They'll put a Lima graft at one place. So in that patient, I think BVS with the PCI is a better option.
Right,
Agreed.
but I think since
Second
we have
value?
taken,
I agree with Dr.
Yeah.
Clare's view.
Yeah. I think it's just important for us to understand.
So,
Just
Christoph,
merely
I,
somebody tells you a syntax score,
Yeah,
does
doesn't
not
mean-
tell you everything about the case.
especially the long-term results.
Yes.
But now they have decided to do it sort of by intervention. Any comments about taking an imaging technique?
No, in this case, with Dr. Daber's case, I think when he's doing left main, I think intravascular ultrasound will be helpful, and
Take it up.
particularly it's a calcified lesion, and he had difficulty in getting the balloon. So maybe if a pre-procedure IOS would have given us a lot of information, maybe a
Value?
rotation may help us.
I think so.
810.
Yeah.
In any case, one always leans towards doing imaging when you are handling distal left main.
Go down.
So you
Dr.
like-
Madikar, Dr. Tan, Dr. Rahman, any comments?
hi, Christoph, this is Hui Chim here. So
Hey,
I,
Hui Chim.
I agree with your strategy of a provisional stent approach for the LAD and diagonal, and but probably you will need 2 stents for the distal left main stenosis. My question here is, would you consider some kind of IVUS guidance here to help you with sizing and positioning and so forth?
Dr. Rahman, what is you're thinking about taking the patient for bypass surgery?
Actually, I will go for the
injection.
provisional strategy from the left main to the LCX. Then I look for the LAD ostium, and by IVAS refer. If it is injured, then I will
Okay,
finish by
now
the
give me-
tap technique.
But
Now-
in addition, I think Dr. Clare's
give me
point
the
is quite
stent.
valid. Can you sort of have a little more discussion about,
Yeah,
Kale, can you have some comments on this?
go with
Dr. Kale, and
You want to ask the panel before that?
having bypass surgery?
Pardon? Regarding?
Dr. Clare has made a comment that this is a really complex, having all the 22 score.
But of course, if you go by the recommendations of all our associations whom we believe a lot, bypass surgery is the first choice. But if the patient has decided an intervention and this can be today done so easily and effectively, I think that's a fair enough option. May not be the number 1 option. Having said that, for me, left main still remains imaging technique related intervention. I would love to know from Dr. Naber and from the members here present, the senior members, whether they now consider that intervention, the imaging is an optional event for left main or it is a must.
Dr. Madikar, then Dr. Vijay, any comment?
What?
I think in this patient we have first again discussed bypass versus angioplasty. You need to have some compelling reason to go ahead and do angioplasty
give
with
me injection.
multivessel stenting. We are underestimating a little bit of risk of restenosis over a period of time, not only in the first year,
I think it's good,
over
huh?
a period of time. So if you look at long-term
here.
disease-free survival,
Okay, go okay.
definitely bypass is good. But when you do such kind of techniques, would you like to consider rota first to have better apposition of stents
12,
because
13, 14, go
that's
up
the
to
most
16.
important point which may decide the long-term survival of the stents in this patient.
And
16?
yeah. We can see now there is a stent
Go
is
down.
being placed at the left main right down to the circumflex. Dr. Tan, can you have a comment about this stent? Did you see that stent is going from left main to circumflex? So we know that, the angulation of the left main to circumflex, when you put a stent, there are some issues about in-stent restenosis, further maze. Any comment on that from the literature?
So I think the best way to ensure the best long-term outcome results for
zero.
osteoarthritis is to get
And
the
the
best
balloon, the big
MLA
balloon?
that you can proceed
no, big balloon.
intraprocedurally. So
4.5,
that's
no?
why I say
You want
IVUS is very
4.5?
helpful
4.5
here.
balloon.
4.5.
Right now, there seems to be already a waste in the ostium.
4.5
I would use IVUS to guide my
4.58.
post-deal inflation here. But looking at the way Christoph is doing it, looks like he might be going for a keloid stent strategy.
So maybe I can just quickly comment. The point is the following. We can take an IVUS before for sizing. We know where the plug is. We can do all that. At the end, the stents from 3-0 onwards. Maybe you can, I can look to the people. So the.
We'll take one shot. We have not taken a shot.
Are
we
you
take a
planning
shot?
to culate,
What am I doing
culate
now?
in this case?
Just a quick shot, okay. Go, quick shot. Okay, it's all fine. So maybe I can just look. So the point is the stents from 3.0 onwards are all the same. They are just mounted on different balloons. So I need to size my stent to the distal vessel. Here we have a big discrepancy between the left main and the circumflex. So I will take a stent that fits the circumflex, and then I can take it up to 4.5 or 5. And I agree with Hui Chim that if I'm not sure if I can remove the waist fully or whatsoever, I will need IVUS guidance maybe at the end to have a look. At the moment, I will now take a 4.5 balloon and do a pot in the left main and see how we come out. And then I would like to reopen to the LAD, and then we see. This is now my 4.5 balloon here, which goes in.
This is Dr. Bang. I would
Hello?
like to ask you, looking at the ostium after the stenting of the circumflex particularly,
Yeah.
I think cutting balloon or some sort of angiosculpt should have been used before stenting this. Because
Yeah,
it looks
I'm-
like it has not opened up. Now, this will produce more restenosis chances
Yes,
in
I'm-
long term.
Okay, is this a non-compliant balloon? So I'm quite happy with your comment. Unfortunately, I don't know if a cutting balloon would really bring a better result. We talk about that, but we never show it. Can I just quickly see the position of the balloon?
Right, you got 4 minutes time. By the time we just
Yeah.
switch over to the other
Inject a
lab.
little bit. Yeah, which is fine. Just inject.
Christoph,
I think we're good here.
Christoph,
Go up, go up.
Maybe tap.
Christoph, this is Hui Chim here again.
Hi,
You
Hui
know,
Chim.
the osteocircumflex stent appears to be probably a little bit under-deployed here.
Right.
Sometimes I will,
deflate
you know,
Okay.
if you don't, I would actually optimize the ostium circumflex first.
I'm doing
in
it.
addition to the ports, because once you put in a stent through the stent struts into the LAD, I have seen
Give me
cases where the
3.5 NC.
osteocircumflex now becomes collapsed and
Yes.
very difficult to go through.
Hui Chim, I fully agree. And you could see maybe from our attempt to do the pot that the balloon moved out backwards. So
Sorry, but what size of balloon was this?
that was a 4.5 for the pot. But it moved out backwards. You can see nicely here. So I agree with Hui Chim. That is a good suggestion. We will do first optimize the ostium with the 3.5 NC balloon and go just straight over the ostium and make it as big as possible, and then go again with our pot and then rewire the LED. So when you come back next time, we most
No, you
likely
can
will
continue.
have
You got
rewired.
another 2 minutes if you could continue.
Okay, wonderful.
What is your plan? Is it going to be culotte or going to be plan a tap?
My plan would be one stent, if it's possible, because there's not much disease in the LAD.
Sorry, I didn't hear. What your plan is?
One stent, if possible.
One stent?
One stent. So you leave LAD. Any comments from the panelists that, you know,
Yeah, I think
planning to leave LAD completely unattended?
If you go from left main to circumflex stenting and leave the ostium of the LAD as it is without any stent, then chances of this coming back is even higher.
The IVUS study tells us that 90% of the distal left main has got some kind of osteo-LAD involvement here.
Yeah, we can see then.
We will
higher.
take a picture
10,
and see,
12,
but the ostium
18,
LAD is already looking
20.
not normal after the stent.
I think there's a great paper published in European Heart Journal by Dr. Fajad's team, and they have shown that if you just do a circumflex and with angulation, the long-term outcome is not good. The chances of having MACE, instant restenosis is phenomenally high as compared to if you just leave LAD completely unattended.
Okay, what we will show us please the result immediately after stenting.
Show that.
Go for EDS.
Can we show it?
Selected
Okay.
stenting.
Now please go to the result after stenting. After stenting.
After standing.
Yeah?
Previous. Yeah.
No? Yeah.
Yeah,
And
from
now
there you
next.
can start.
Okay, from here we start. Just keep it there. We will do the rest now live.
Then
Okay. Now what you see here is, as you see, the implantation of a 3-0 very long stent in the circumflex and the left main, and some people started talking about sensible, incomplete revascularization or something. So let me show you the next. Next, please. So this was a balloon 3.5. No, that was our attempt to do a pot with the 4.5.
4.5.
Next, please. Now this was a 3.0. Next, please. A 3.5, but you still see the edge. Next, please. And now again, it doesn't work. Next, please.
Calcium,
Okay, now we still at the edge. And now what you see here is, again, the 3.5 at 24 atmospheres. And you can see that the waste is gone. Yeah? And you see now a very nice result here in the proximal circumflex, and you see some impingement of the LED. We will see if it will be enough to just do one stent technique. If it's not enough, which I can imagine from this image, we will do a TAP technique. So where we are at the moment, so the waste is gone. I think there are no concerns about that anymore.
You
and
rewired it.
And what you see here is we rewired the complete thing. Can you now please go back to the caudal?
LAO caudal.
And we placed a 3-0 balloon in the LAD, and for the sake of time, I'm speeding up a little bit things. So I don't wanna wait too long with just dilating one side and the other. So what I'm trying now is to do an immediate kissing. What I'm doing here is pushing a 3.5 balloon in the circumflex, and then we have altogether 6.5, which should resemble about 4.3 or 4.2 millimeters of kissing balloon technique. So now we are quite okay, and we will now start with the kissing balloon. The important thing is that we drop the pressure in the circumflex last. So who has the circumflex? You have it, okay? Yeah. Okay, please go up with both balloons. Go to 10, go to 12. Both balloons?
Go to 10. Go, 10. Both balloons, 10.
10.
Both.
Go. Okay,
Yeah.
very nice. Okay, now you go down first. Okay, and now we go down with the circumflex.
Yeah, go down.
Okay, fine. So at least we opened, and now we can see if we would like to take a stent in the LED as well. Let me remove them and do a shot here, that you see something to discuss.
Yeah, shot.
Injection. Okay, can you inject? Okay, thank you very much. Looks quite good.
Looks better.
The question is if we need to stent the proximal LED, which had not much disease. And for this, I would like to take an IVUS and have a look on the ostium of the LED now.
Yeah.
Dr. Nabar, I had a question. In your routine practice, do you do these left mains without imaging?
You should stent because
You always do imaging.
No, I use imaging if I have a question which I can clarify. I never use imaging without a clear question that I have. And here I now have the question, should I stent the LAD ostium? So because you were citing Dr. Fajade, I was working with him for some time.
What is the
and this
percentage
what
of
we
time that you have a question to be answered with
Well,
imaging?
let's say, I would say maybe in 30% of cases, I would like to take a look.
LED where? Which is the LED where?
Let me see, I check that.
Hi, Christoph, this is Hui Chim here again.
Yeah.
I am just feeling here that with or without the IVUS right now, it is going to be hard to leave the ostium of the LAD alone. If
Could
you
be.
look at the LAD, ostium is much smaller than the distal
Could be, yes.
distal diameter, and that now that you have balloon angioplasty, the ostium of LAD, some kind of trauma may have already occurred, and
I
this
agree
may
with
be
you.
a spot for restenosis, which is a bad spot. So I would err on the side of caution and just go ahead with stent.
I agree with you, Huachim. Most likely we will end up like this, but because we discussed it, I would like to take a look and see now, and then we can, we don't need to discuss. I believe also I will end up putting a short 3.5 stent in the LAD, which would then end up as being a TAP, which is a good procedure. Finally, 2 stents, which is then okay. But we made the attempt of having 1 stent. If this is not possible, we go with 2, which is absolutely no problem. I mean, you can go with 2 without any doubt. Let's have a look how it looks in the IVUS. So we have the IVUS probe here. And maybe we take a 3.5, 10 or something stent.
Yeah.
12, 10, 10.
If you could show us quickly, in
10.
1 minute time, you will be disconnected.
3.5, 12 we have. Yeah.
If I can
What
make it.
size of stents he's taking? Is it-
What size is it? What size you are taking now?
This is now an IVUS, but I would
we are
take a
planning to do
3.5. For the LAD, I would take a 3.5.
3.5. Length?
Length short.
12.
I believe it's 12 maximum.
12.
But we will see with the IVUS now.
We
now,
have a 8 also, but I think we'll require
But
12.
for this question, I think the IVUS is then helpful. and we can tell after the IVUS.
నొప్పి లేదులే తగ్గిద్దిలే
So can we go
Don't
in?
worry.
So we could easily end up with a tub,
No.
which is for me absolutely fine, which is good. Are we okay? Okay.
Okay. Go ahead.
Absolutely.
I would.
So if you, so it's a good demonstration of the case. We are going to be disconnected in a minute.
Yeah, I tried to show you the proximal.
It's 3.5.
You see the IVUS, yeah?
Yeah, we are seeing.
3.5 to 4 almost.
A lot of plaque.
Please,
Where
yeah, go in this. Yeah, there's a
3.5 to
lot
4.
of plaque. We will take at least a 3.5, maybe even 1, 2, 3, 4. It's
nearly
4.
4.
I would take a 4.
Nearly 4.
After IVUS, I would take a 4. So my strategy would be, can you pull back that we
some calcium as
see
well.
the stent?
7 o'clock, 8 o'clock.
Yeah, I see the same.
Spotty calcium.
Yeah, I pull back manually. Yeah, here and here. This is very nice. Here you see, it's heavily diseased in the osteum, and now I pull back, and here this is our left main. We have quite good apposition here. You see, this looks nice. But so my strategy is clear. After the IVUS, I will do a 4.0 12 millimeter a stent for the LAD. Then I will do kissing again, and I will finish with a 4.5 port.
You have?
I will finish with a 4.5 port. So if you want to disconnect, this is my strategy. You want to see a final shot,
Right,
how we
actually
look at the
it's
moment?
very nice. What do you think, Dr. Mehta? How was the case? You could conclude the session.
Inject.
I think we
Dr.
just...
Sengu got a quick comment.
Yeah, okay.
Go ahead.
Okay,
in
4.5.
retrospectively, what I would like
4.5,
to,
12.
I feel in this case is one, if you had done an IVUS pre-procedure,
Yeah.
we would have clearly known that there's a lot of osteal disease, and we would have pre-dilated the distal left main adequately, because he had a lot of difficulty in post-dilating after the stent implantation. And then definitely it would have been a two-stent strategy. The first stent from left main to circumflex, I have a lot of concern in putting a stent into the circumflex.
Correct, agreed.
Unless you do a QLOT, it's better to put the first stent into the circumflex. So if he's planning a TAP or any other two
Do LAD first.
Yeah, it would have
Agreed.
been
That we
from left main
discussed.
to LAD, or if it's a DK crush, we can do the circ first also.
Correct.
If you had not done the imaging IVUS before, it would have been a clear two-stent strategy, and you could have planned appropriately to plan the first stent into the LAD, or a mini crush with the first stent in the circumflex.
Agreed.
The
Dr.
second
Mehta, would you
is
like to conclude
basing.
I think it is very good comment. Number one, let us do, all the data, Nordic 1, Nordic 2, Nordic 3, and Nordic 4, that even a provisional stenting is good enough for a large size side branch, Nordic 4. Now I want to tell you, I can take the fact the other way, that the provisional stenting can produce as good a result in terms of MACE as two-stent strategy. If that is so, then in that situation, I could take it the other way. You don't have to worry about increased MACE when you use a two-stent strategy also. That means do not hesitate or don't be too intimidated when you want to use a two-stent strategy, because the complications are same as provisional. I can take the factor the other way also. So I think whenever it is necessary, if your gut feeling or your mind or your interpretation tells that you should go ahead with the two-stent strategy right from go.
Dr. Ashwin, I know it's an off-level indication, but I think the left main or bifurcation lesions, I feel it should be a good idea to use bioabsorb after preparing the bed very nicely, because, I don't like the idea of too much of metal in the left main forever in the life of a person.
There is no data.
I think thank you very much. Thank you to all the expert panelists, colleagues, and Dr. Mehta. They're sort of chairing the session.
Thank you very much,
Thank you for being
chairpersons.
wonderful audience.